Question 1. A client with severe vomiting for 3 days presents with weakness and confusion. The ABG results are pH 7.48, PaCO2 46 millimeters mercury, HCO3 negative 32 milliequivalents per liter. Which acid-base imbalance is present? A. Respiratory alkalosis. B. Metabolic alkalosis. C. Metabolic acidosis. D. Respiratory acidosis. Answer: B. Metabolic alkalosis. Rationale: the pH is above 7.45, indicating alkalosis. The HCO3 negative is elevated, which identifies the cause as metabolic. Vomiting leads to loss of gastric acid, causing metabolic alkalosis. The slightly elevated PaCO2 indicates respiratory compensation. Question 2. A patient with chronic obstructive pulmonary disease, COPD, presents with the following ABG results: pH 7.32, PaCO2 55 millimeters mercury, HCO3 negative 28 milliequivalents per liter. What is the correct interpretation? A. Uncompensated respiratory acidosis. B. Partially compensated respiratory acidosis. C. Fully compensated respiratory alkalosis. D. Metabolic acidosis. Answer: B. Partially compensated respiratory acidosis. Rationale: the pH is acidic, under 7.35, and the PaCO2 is elevated, indicating respiratory acidosis. The HCO3 negative is slightly elevated, showing the kidneys are attempting to compensate. Because the pH is still abnormal, the condition is partial compensation. Question 3. A patient experiencing a panic attack has ABG values pH 7.50, PaCO2 30 millimeters mercury, HCO3 negative 24 milliequivalents per liter. Which condition is present? A. Respiratory alkalosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis. Rationale: the high pH indicates alkalosis. The PaCO2 is low, meaning excessive CO2 is being exhaled due to hyperventilation. The bicarbonate is normal, indicating no metabolic compensation yet. Question 4. A patient with diabetic ketoacidosis, DKA, has the following ABG: pH 7.25, PaCO2 28 millimeters mercury, HCO3 negative 14 milliequivalents per liter. Which acid-base disorder is present? A. Respiratory alkalosis. B. Metabolic acidosis with compensation. C. Respiratory acidosis. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with compensation. Rationale: the low pH indicates acidosis. The low bicarbonate identifies the cause as metabolic. The PaCO2 is decreased because the patient is hyperventilating, Kussmaul respirations, to blow off CO2, showing respiratory compensation. Question 5. A patient with opioid overdose presents with ABG results pH 7.28, PaCO2 60 millimeters mercury, HCO3 negative 25 milliequivalents per liter. What is the correct interpretation? A. Respiratory acidosis. B. Metabolic acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: A. Respiratory acidosis. Rationale: the low pH indicates acidosis. The PaCO2 is elevated, meaning CO2 is retained due to hypoventilation caused by opioid-induced respiratory depression. The bicarbonate remains normal, indicating no compensation yet. Question 6. A patient with prolonged diarrhea has ABG results pH 7.31, PaCO2 33 millimeters of mercury, HCO3 minus 18 milliequivalents per liter. Which disorder is present? A. Metabolic acidosis with compensation. B. Respiratory alkalosis. C. Respiratory acidosis. D. Metabolic alkalosis. Answer: A. Metabolic acidosis with compensation. Rationale: the pH is acidic and HCO3 minus is decreased, indicating metabolic acidosis. Diarrhea causes loss of bicarbonate. The low PaCO2 reflects respiratory compensation through hyperventilation. Question 7. A client with severe anxiety is hyperventilating. ABG results show pH 7.47, PaCO2 33 millimeters of mercury, HCO3 minus 23 milliequivalents per liter. Which condition does this indicate? A. Respiratory alkalosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis. Rationale: hyperventilation causes excessive removal of CO2, leading to low PaCO2 and increased pH. Because bicarbonate remains normal, the condition is uncompensated respiratory alkalosis. Question 8. A patient with renal failure has the following ABG: pH 7.29, PaCO2 34 millimeters of mercury, HCO3 minus 16 milliequivalents per liter. What is the most accurate interpretation? A. Respiratory acidosis. B. Metabolic acidosis with compensation. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with compensation. Rationale: the low bicarbonate indicates metabolic acidosis. Kidney failure prevents the body from excreting acids. The low PaCO2 shows respiratory compensation through increased ventilation. Question 9. A client receiving excessive mechanical ventilation has ABG values pH 7.52, PaCO2 28 millimeters of mercury, HCO3 minus 24 milliequivalents per liter. Which acid-base imbalance is present? A. Respiratory alkalosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis. Rationale: mechanical ventilation can cause overventilation, reducing PaCO2 levels. Low CO2 raises blood pH, producing respiratory alkalosis. Question 10. A patient with severe asthma exacerbation shows the following ABG: pH 7.30, PaCO2 52 millimeters of mercury, HCO3 minus 26 milliequivalents per liter. Which condition is most likely? A. Respiratory acidosis. B. Respiratory alkalosis. C. Metabolic acidosis. D. Metabolic alkalosis. Answer: A. Respiratory acidosis. Rationale: asthma exacerbations can cause air trapping in hypoventilation, leading to CO2 retention. Elevated PaCO2 with low pH indicates respiratory acidosis. Question 11. A patient with septic shock is tachypneic. ABG results show pH 7.46, PaCO2 30 millimeters mercury, HCO3 minus 21 milliequivalents per liter. Which acid-base disorder is present? A. Metabolic alkalosis. B. Respiratory alkalosis with metabolic compensation. C. Metabolic acidosis. D. Respiratory acidosis. Answer: B. Respiratory alkalosis with metabolic compensation. Rationale: the pH is alkalotic, greater than 7.45. The PaCO2 is decreased, identifying the primary disorder as respiratory alkalosis. The HCO3- is slightly decreased, indicating the kidneys are compensating by excreting bicarbonate. This pattern is common in early sepsis with hyperventilation. Question 12. A patient with prolonged COPD has the following ABG values: pH 7.36, PaCO2 60 mm mercury, HCO3- 34 milliequivalents per liter. How should this ABG be interpreted? A. Fully compensated respiratory acidosis. B. Metabolic alkalosis. C. Partially compensated respiratory alkalosis. D. Uncompensated respiratory acidosis. Answer: A. Fully compensated respiratory acidosis. Rationale: the PaCO2 is elevated, indicating respiratory acidosis. The bicarbonate is significantly elevated, showing renal compensation. The pH is within normal range, meaning the compensation is complete. Question 13. A trauma patient receiving excessive ventilation on a ventilator has ABG results: pH 7.55, PaCO2 25 mm mercury, HCO3- 22 milliequivalents per liter. What is the most likely interpretation? A. Respiratory alkalosis. B. Metabolic alkalosis. C. Metabolic acidosis. D. Respiratory acidosis. Answer: A. Respiratory alkalosis. Rationale: the very high pH indicates alkalosis. The low PaCO2 confirms respiratory alkalosis due to excessive ventilation. The bicarbonate remains normal because renal compensation has not yet occurred. Question 14. A patient with diabetic ketoacidosis receiving treatment develops this ABG: pH 7.40, PaCO2 30 mm per mercury, HCO3- 18 milliequivalents per liter. What does this indicate? A. Normal ABG. B. Fully compensated metabolic acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: B. Fully compensated metabolic acidosis. Rationale: the bicarbonate is low, indicating metabolic acidosis. The PaCO2 is decreased, showing respiratory compensation. Because the pH has returned to normal, the disorder is fully compensated. Question 15. A patient with severe pneumonia develops the following ABG: pH 7.29, PaCO2 50 mm per mercury, HCO3- 24 milliequivalents per liter. Which interpretation is correct? A. Respiratory acidosis. B. Metabolic acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: A. Respiratory acidosis. Rationale: the pH is acidic and the PaCO2 is elevated, indicating respiratory acidosis caused by impaired gas exchange. The bicarbonate remains normal, meaning no renal compensation yet. Question 16. A patient with salicylate toxicity has the following ABG: pH 7.48, PaCO2 27 mm per mercury, HCO3- 20 milliequivalents per liter. Which interpretation is most accurate? A. Respiratory alkalosis with metabolic acidosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Pure respiratory alkalosis. Answer: A. respiratory alkalosis with metabolic acidosis. Rationale: salicylate poisoning causes mixed acid-base disorders. Early toxicity stimulates the respiratory center, causing respiratory alkalosis, while metabolic acids accumulate, causing metabolic acidosis, resulting in this mixed pattern. Question 18. A ventilated ICU patient has the following ABG: pH 7.21, PaCO2 62 mm per mercury, HCO3- 25 milliequivalents per liter. What is the interpretation? A. Respiratory acidosis. B. Metabolic acidosis. C. Metabolic alkalosis. D. Respiratory alkalosis. Answer: A. Respiratory acidosis. Rationale: the pH is severely acidic and the PaCO2 is markedly elevated, indicating respiratory acidosis. The bicarbonate is still normal, suggesting acute respiratory failure without renal compensation. Question 18. A patient with severe dehydration and vomiting shows the following ABG: pH 7.49, PaCO2 48 millimeters of mercury, HCO3- 34 milliequivalents per liter. Which condition is present? A. Metabolic alkalosis with compensation. B. Respiratory alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Metabolic alkalosis with compensation. Rationale: the elevated pH indicates alkalosis. The high bicarbonate confirms metabolic alkalosis, commonly caused by vomiting. The increased PaCO2 shows respiratory compensation through hypoventilation. Question 19. A patient with advanced renal failure presents with the following ABG: pH 7.19, PaCO2 32 millimeters of mercury, HCO3- 12 milliequivalents per liter. What is the most accurate interpretation? A. Respiratory acidosis. B. Metabolic acidosis with respiratory compensation. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with respiratory compensation. Rationale: the very low bicarbonate indicates metabolic acidosis due to kidney failure. The PaCO2 is decreased because the lungs are compensating through hyperventilation. Question 20. A patient with pulmonary embolism has the following ABG values: pH 7.47, PaCO2 31 millimeters of mercury, HCO3- 23 milliequivalents per liter. Which interpretation is correct? A. Respiratory alkalosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis. Rationale: pulmonary embolism commonly causes hyperventilation due to hypoxemia, leading to low PaCO2 and elevated pH, consistent with respiratory alkalosis. Question 21. A 68-year-old patient with septic shock is intubated and mechanically ventilated. ABG results are pH 7.33, PaCO2 28 millimeters of mercury, HCO3- 15 milliequivalents per liter. Which acid-base disorder is present? A. Respiratory alkalosis. B. Metabolic acidosis with respiratory compensation. C. Respiratory acidosis. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with respiratory compensation. Rationale: the pH is acidic. The HCO3- is markedly reduced, indicating metabolic acidosis, commonly seen in lactic acidosis from septic shock. The low PaCO2 reflects compensatory hyperventilation to reduce acid load. Question 22. A patient with advanced COPD on long-term oxygen therapy presents with pH 7.37, PaCO2 62 mm of mercury, HCO3- 35 milliequivalents per liter. What is the correct interpretation? A. Fully compensated respiratory acidosis. B. Partially compensated respiratory acidosis. C. Metabolic alkalosis. D. Respiratory alkalosis. Answer: A. Fully compensated respiratory acidosis. Rationale: the PaCO2 is significantly elevated, indicating respiratory acidosis due to chronic CO2 retention. The HCO3- is elevated from renal compensation. Because the pH is within normal range, this represents complete compensation, typical in chronic COPD. Question 23. A patient in diabetic ketoacidosis is breathing rapidly. ABG values show pH 7.18, PaCO2 25 mm mercury, HCO3- 10 milliequivalents per liter. Which condition is present? A. Respiratory acidosis. B. Metabolic acidosis with respiratory compensation. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with respiratory compensation. Rationale: the severely low bicarbonate confirms metabolic acidosis caused by ketone accumulation. The low PaCO2 indicates compensatory hyperventilation, Kussmaul respirations. Question 24. A ventilated ICU patient has the following ABG: pH 7.52, PaCO2 29 mm mercury, HCO3- 23 milliequivalents per liter. What is the most accurate interpretation? A. Respiratory alkalosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis. Rationale: the pH is elevated, and the PaCO2 is reduced, indicating respiratory alkalosis. In ventilated patients, this often occurs when tidal volume or respiratory rate is set too high, causing excessive CO2 removal. Question 25. A patient with prolonged vomiting presents with pH 7.50, PaCO2 47 mm mercury, HCO3- 35 milliequivalents per liter. Which acid-base imbalance is present? A. Respiratory alkalosis. B. Metabolic alkalosis with respiratory compensation. C. Respiratory acidosis. D. Metabolic acidosis. Answer: B. Metabolic alkalosis with respiratory compensation. Rationale: the elevated bicarbonate identifies metabolic alkalosis, commonly due to loss of gastric acid during vomiting. The PaCO2 is elevated because the lungs compensate by hypoventilating to retain CO2. Question 26. A patient with ARDS is receiving mechanical ventilation. ABG results show pH 7.28, PaCO2 50 mm mercury, HCO3- 23 milliequivalents per liter. What is the correct interpretation? A. Respiratory acidosis. B. Metabolic acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: A. Respiratory acidosis. Rationale: the acidic pH with elevated PaCO2 indicates respiratory acidosis. ARDS causes impaired alveolar ventilation, leading to CO2 retention. Bicarbonate remains normal, suggesting acute respiratory failure. Question 27. A patient with severe liver failure has the following ABG: pH 7.46, PaCO2 30 mm mercury, HCO3 negative 21 milliequivalents per liter. Which interpretation is correct? A. Respiratory alkalosis with compensation. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis with compensation. Rationale: liver failure often causes chronic hyperventilation, resulting in respiratory alkalosis. The reduced bicarbonate reflects renal compensation. Question 28. A patient with severe diarrhea presents with pH 7.30, PaCO2 34 mm mercury, HCO3 negative 17 milliequivalents per liter. Which disorder is present? A. Respiratory acidosis. B. Metabolic acidosis with respiratory compensation. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with respiratory compensation. Diarrhea leads to loss of bicarbonate from the gastrointestinal tract, causing metabolic acidosis. The reduced PaCO2 indicates compensatory hyperventilation. Question 29. A ventilated patient after traumatic brain injury has the following ABG: pH 7.55, PaCO2 26 mm mercury, HCO3 negative 22 milliequivalents per liter. What is the most likely cause? A. Respiratory alkalosis due to hyperventilation. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis due to hyperventilation. Rationale: hyperventilation reduces PaCO2, increasing pH. In traumatic brain injury, controlled hyperventilation may be used to reduce intracranial pressure, resulting in respiratory alkalosis. Question 30. A patient with renal failure and pneumonia has the following ABG: pH 7.21, PaCO2 55 mm mercury, HCO3 negative 18 milliequivalents per liter. What is the correct interpretation? A. Respiratory acidosis only. B. Metabolic acidosis only. C. Mixed respiratory and metabolic acidosis. D. Metabolic alkalosis. Answer: C. Mixed respiratory and metabolic acidosis. Rationale: the pH is severely acidic. The PaCO2 is elevated, indicating respiratory acidosis due to inadequate alveolar ventilation, but the bicarbonate remains normal, indicating acute respiratory failure without compensation. Question 32. A mechanically ventilated patient with ARDS has the following ABG: pH 7.31, PaCO2 48 mm mercury, HCO3 negative 24 milliequivalents per liter. What acid-base disorder is present? A. Respiratory acidosis. B. Metabolic acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: A. Respiratory acidosis. Rationale: the low pH indicates acidosis, and the PaCO2 is elevated, confirming respiratory acidosis due to inadequate alveolar ventilation. The bicarbonate remains normal, indicating acute respiratory failure without compensation. Question 33. A patient with salicylate poisoning has ABG results at pH 7.44, PaCO2 25 mm mercury, HCO3 negative 16 milliequivalents per liter. Which interpretation is correct? A. Respiratory alkalosis. B. Metabolic acidosis. C. Mixed respiratory alkalosis and metabolic acidosis. D. Metabolic alkalosis. Answer: C. Mixed respiratory and metabolic acidosis. Rationale: Both PaCO2 and bicarbonate are decreased. Salicylate toxicity causes respiratory alkalosis from central respiratory stimulation and metabolic acidosis from accumulation of organic acids, resulting in a mixed disorder.
Question 34. A patient with prolonged nasogastric suction develops the following ABG: pH 7.51, PaCO2 46 millimeters mercury, HCO3 negative 35 MEq per liter. Which disorder is present? A. Respiratory alkalosis. B. Metabolic alkalosis with respiratory compensation. C. Respiratory acidosis. D. Metabolic acidosis. Answer: B. Metabolic alkalosis with respiratory compensation. Rationale: loss of gastric acid from NG suction leads to metabolic alkalosis. The elevated bicarbonate confirms metabolic origin, and the increased PaCO2 reflects compensatory hypoventilation. Question 35. A patient with severe asthma exacerbation develops this ABG: pH 7.27, PaCO2 55 millimeters mercury, HCO3 negative 26 MEq per liter. What is the interpretation? A. Respiratory acidosis. B. Respiratory alkalosis. C. Metabolic acidosis. D. Metabolic alkalosis. Answer: A. Respiratory acidosis. Rationale: airway obstruction in severe asthma causes CO2 retention. The elevated PaCO2 with acidic pH indicates respiratory acidosis, suggesting worsening ventilatory failure. Question 36. A patient with chronic renal failure has the following ABG: pH 7.34, PaCO2 30 millimeters mercury, HCO3 negative 16 MEq per liter. Which interpretation is correct? A. Metabolic acidosis with respiratory compensation. B. Respiratory alkalosis. C. Respiratory acidosis. D. Metabolic alkalosis. Answer: A. Metabolic acidosis with respiratory compensation. Rationale: kidney failure leads to retention of acids and reduced bicarbonate, causing metabolic acidosis. The low PaCO2 indicates compensatory hyperventilation to remove carbon dioxide. Question 37. A ventilated patient following head trauma has ABG values pH 7.56, PaCO2 24 millimeters mercury, HCO3 negative 21 MEq per liter. What acid-base disturbance is present? A. Respiratory alkalosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis. Rationale: the very low PaCO2 indicates excessive ventilation, causing respiratory alkalosis. Hyperventilation is sometimes used in neurocritical care to reduce intracranial pressure. Question 38. A patient with diabetic ketoacidosis receiving treatment has ABG results pH 7.38, PaCO2 32 millimeters mercury, HCO3 negative 19 MEq per liter. What is the most accurate interpretation? A. Fully compensated metabolic acidosis. B. Respiratory alkalosis. C. Metabolic alkalosis. D. Respiratory acidosis. Answer: A. Fully compensated metabolic acidosis. Rationale: the bicarbonate remains low, indicating metabolic acidosis from DKA. The PaCO2 is decreased due to compensatory hyperventilation. The pH has normalized, indicating complete compensation. Question 39. A patient with pneumonia develops the following ABG: pH 7.32, PaCO2 52 millimeters mercury, HCO3 negative 26 MEq per liter. Which disorder is present? A. Respiratory acidosis. B. Metabolic acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: A. Respiratory acidosis. Rationale: the acidic pH with elevated PaCO2 indicates respiratory acidosis caused by impaired ventilation and gas exchange from pneumonia. Question 40. A patient with septic shock and renal failure has the following ABG: pH 7.18, PaCO2 32 millimeters mercury, HCO3 negative 12 MEq per liter. What is the correct interpretation? A. Respiratory acidosis. B. Metabolic acidosis with respiratory compensation. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with respiratory compensation. Rationale: the very low bicarbonate indicates severe metabolic acidosis, commonly from lactic acidosis and renal failure. The reduced PaCO2 reflects compensatory hyperventilation.
Question 41. A patient with septic shock and acute renal failure has the following ABG: pH 7.22, PaCO2 50 millimeters mercury, HCO3 minus 19 milliequivalents per liter. Which interpretation is correct? A. Respiratory acidosis. B. Metabolic acidosis. C. Mixed respiratory and metabolic acidosis. D. Metabolic alkalosis. Answer: C. Mixed respiratory and metabolic acidosis. Rationale: the pH is markedly acidic. The PaCO2 is elevated, indicating respiratory acidosis, while the HCO3- is reduced, indicating metabolic acidosis. The presence of both abnormalities confirms a mixed acid-base disorder, common in critically ill patients with respiratory failure and renal dysfunction. Question 42. A mechanically ventilated patient has the following ABG: pH 7.48, PaCO2 30 millimeters mercury, HCO3- 22 milliequivalents. What is the most likely cause? A. Respiratory alkalosis from excessive ventilation. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis from excessive ventilation. Rationale: the elevated pH with decreased PaCO2 indicates respiratory alkalosis. In ventilated patients, this commonly occurs when respiratory rate or tidal volume is set too high, causing excessive CO2 removal. Question 43. A patient with severe diarrhea and dehydration presents with pH 7.28, PaCO2 33 millimeters mercury, HCO3- 16 milliequivalents. Which acid-base imbalance is present? A. Respiratory acidosis. B. Metabolic acidosis with respiratory compensation. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with respiratory compensation. Rationale: severe diarrhea leads to loss of bicarbonate, resulting in metabolic acidosis. The low PaCO2 reflects compensatory hyperventilation aimed at reducing acidity. Question 44. A patient with COPD exacerbation has the following ABG: pH 7.33, PaCO2 58 millimeters mercury, HCO3- 29 milliequivalents. Which interpretation is most accurate? A. Respiratory acidosis with partial compensation. B. Fully compensated respiratory acidosis. C. Metabolic alkalosis. D. Respiratory alkalosis. Answer: A. Respiratory acidosis with partial compensation. Rationale: the pH remains acidic while the PaCO2 is elevated, confirming respiratory acidosis. The bicarbonate is elevated, indicating renal compensation, but because the pH is still abnormal, the compensation is partial. Question 45. A trauma patient receiving aggressive ventilation develops the following ABG: pH 7.54, PaCO2 27 mm mercury, HCO3 minus 23 milliequivalents. What is the interpretation? A. Respiratory alkalosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Respiratory alkalosis. Rationale: the high pH with low PaCO2 indicates respiratory alkalosis. This is typically caused by excessive mechanical ventilation, leading to excessive CO2 removal.
Question 46. A patient with diabetic ketoacidosis presents with pH 7.16, PaCO2 24 millimeters of mercury, HCO3 minus 9 milliequivalents per liter. Which disorder is present? A. Respiratory alkalosis. B. Metabolic acidosis with respiratory compensation. C. Respiratory acidosis. D. Metabolic alkalosis. Answer: B. Metabolic acidosis with respiratory compensation. Rationale: the very low bicarbonate confirms metabolic acidosis due to accumulation of ketone bodies. The low PaCO2 reflects compensatory hyperventilation, Kussmaul breathing. Question 47. A patient receiving loop diuretics develops the following ABG: pH 7.49, PaCO2 45 millimeters of mercury, HCO3 minus 33 milliequivalents per liter. What is the most accurate interpretation? A. Metabolic alkalosis with respiratory compensation. B. Respiratory alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. Metabolic alkalosis with respiratory compensation. Rationale: loop diuretics cause loss of hydrogen and potassium ions, resulting in metabolic alkalosis. The elevated PaCO2 indicates compensatory hypoventilation. Question 48. A patient with severe pneumonia and sepsis has the following ABG: pH 7.34, PaCO2 48 millimeters of mercury, HCO3 minus 26 milliequivalents per liter. Which interpretation is correct? A. Respiratory acidosis with compensation. B. Metabolic acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: A. Respiratory acidosis with compensation. Rationale: the PaCO2 is elevated, indicating respiratory acidosis from impaired ventilation. The slightly elevated bicarbonate suggests renal compensation, although the pH remains slightly acidic. Question 50. A critically ill patient with liver failure develops this ABG: pH 7.47, PaCO2 29 millimeters of mercury, HCO3 minus 21 milliequivalents per liter. Which acid-base disturbance is present? A. Respiratory alkalosis with metabolic compensation. B. Metabolic alkalosis. C. Respiratory acidosis. D. Metabolic acidosis. Answer: A. respiratory alkalosis with metabolic compensation. Rationale: liver failure often leads to chronic hyperventilation, producing respiratory alkalosis. The slightly reduced bicarbonate reflects renal compensation. Question 50. A chronically ill patient with cardiac arrest is resuscitated and develops the following ABG: pH 7.12, PaCO2 60 mm of mercury, HCO3- 18 milliequivalents per liter. What is the correct interpretation? A. Respiratory acidosis. B. Metabolic acidosis. C. Mixed respiratory and metabolic acidosis. D. Metabolic alkalosis. Answer: C. Mixed respiratory and metabolic acidosis. Rationale: the very low pH indicates severe acidemia. The elevated PaCO2 indicates respiratory acidosis, while the reduced bicarbonate indicates metabolic acidosis from lactic acid accumulation during cardiac arrest. This represents a life-threatening mixed disorder.
And that brings us to the end of 50 ABG interpretation questions explained for respiratory nursing. If you were able to work through these scenarios, you're not just memorizing numbers anymore. You're thinking clinically, the same way nurses do in the ICU, emergency department, and critical care units. ABG interpretation is a core skill that helps you quickly identify respiratory failure, metabolic crises, compensation patterns, and life-threatening mixed disorders. Remember this key principle. Always analyze the pH first, identify the primary disturbance, and then determine whether compensation is present. With consistent practice, ABG interpretation becomes faster, clearer, and far more intuitive. If you found this practice helpful, make sure to like the video, subscribe to the channel, and turn on notifications so you don't miss our next set of advanced nursing questions. And if you want to challenge yourself even further, check out our other videos covering critical care pharmacology, lab values every nurse must memorize, and high-alert medication safety. Keep practicing, keep sharpening your clinical judgment, and as always, study smart, think clinically, and stay safe in practice.